Sir, we are live now. With all your permission, sir, I'm starting this webinar for today.
Okay.
Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. N.K. Soni, sir. And let me share some of the achievement of sir. Sir has done MD, FRCP from Glasgow, and FACP from USA, FICP, FIACM, and Director Academics and HOD of Internal Medicine at Yatharth Super Specialty Hospital, Greater Noida. And today, sir is going to speak on a topic, management strategy of hyperexia. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Stage is yours. You can proceed from here.
Thank you. Thank you very much. Thank you very much. At the outset, I would like to welcome all my friends who have joined this evening for this very important webinar. Well, we all know that today we are experiencing a heat wave which is prevalent in northern part of India, and the heat wave is very, very severe. And that is why it becomes all the more important as a topic that we should know how to deal with the patients who come with the high-grade fever. So the topic today is hyperpyrexia and hyperthermia. In the next half an hour or so, I'll be dealing with this topic, where I would like to explain the difference between the two, that hyperpyrexia and hyperthermia is, and because these two terms, they look like synonymous, but it is not. The hyperpyrexia is has got a little different mechanism. Hyperthermia has got a little different mechanism altogether. Although the symptoms are the same, that the patient presents with a high-grade fever. And the most of the time, what happens that if it is not treated at an early stage, and that too aggressively, probably the morbidity and mortality also increases. And nowadays, you are reading in the newspapers that in Rajasthan or in the northern part of India, where the temperature is hovering to the tune of around 48, 49, and 50 degrees Celsius, the people on the streets and they are dying, and the police is finding the bodies of these patients who died because of the high temperature. So it becomes all the more important for the clinicians to update their knowledge about the symptoms, sign and symptoms, and the management for hyperpyrexia and hyperthermia. And this is what I will be discussing in the next 25 to 30 minutes. Well, to start with, we should know that what is hyperpyrexia is. The hyperpyrexia is, of course, another term for a very high grade of fever. The medical criteria for hyperpyrexia is when someone is running a body temperature of more than 106.7 degree Fahrenheit or 41.5 degrees Celsius. So that temperature has been, mentioned as a number where people, we label the patient. If the temperature is that much high, that we label that the patient is having hyperpyrexia. Well, fever, hyperthermia, and hyperpyrexia, these are usually the three terms which we use when the patient's body temperature is high. And these three terms of fever, hyperpyrexia, and hyperthermia, these are not synonymous terms. Clinically, practically, and if we see scientifically, these are a little different. Fever, whenever the body temperature is more than 98.6 to 99.6, if it goes beyond that, we call it as that the patient is suffering from fever. When the body temperature is more than 106.7 degree Fahrenheit, we will be call that the patient is having hyperpyrexia. And how hyperthermia is different from hyperpyrexia, that is the physiology in the body which makes the difference, because hyperpyrexia is caused by some organisms or some defect pathophysiology inside the body, where hypothalamus or thermostat of the body gets reset, in the sense that it does not allow the body to lower down the temperature. While hyperthermia is basically because of the external cause. Nowadays, as we are experiencing that the patients, because of the high environmental temperature, their body temperature goes up, and that is called as hyperthermia, where the pathophysiology or thermostat of the body inside the body or in the brain, that does not play any role. So that is basically the difference between the fever, hyperthermia, and hyperpyrexia. Although the treatment remains the same in the majority of the cases, like fever and hyperpyrexia, but for hyperthermia, it is a little different, which I will be discussing in my subsequent slides. Well, to go in a little detail, fever, uh, as it includes very high fever, are never illnesses in themselves. This is the symptomatology only, or it is not the cause of illness, but it is symptoms of the other problems, and like infections, injury, or heat stroke, or whatever. Viral or bacterial infections are most common cause of fever. However, hyperpyrexia, that's not always the case. But whenever body temperature goes up, it's called fever. Whenever body temperature is more than 106.7 degree Fahrenheit, it is hyperpyrexia. Well, so what is hyperpyrexia? The hyperpyrexia is the term for an extraordinarily high fever, which can be observed in the patients with severe infections, whether it is a bacterial infection or it is a viral infection, but most commonly occurs even in the patients with central nervous system hemorrhages. Like pontine hemorrhage is very well known to have a characteristic hyperpyrexia, which does not get relief easily with antibiotics or others, because it is not the bacterial infection which is the cause. So pontine hemorrhage is one example of having the patients having hyperpyrexia, where increased morbidity and mortality we observe in these patients. Burn injuries sometimes results in the release of pro-inflammatory cytokines or pyrogens and catecholamines, which cause the hypermetabolic state, which may lead to the development of hyperpyrexia. And thus these patients of severe burn who develop hyperpyrexia, the mortality is little high in these patients. So hyperpyrexia actually is a medical emergency and is usually fatal if it is not treated aggressively, and that too in the early course of the disease itself. Well, so the difference between hyperpyrexia and hyperthermia, if I say, the hyperpyrexia is a severely elevated core body temperature, which is secondary to an elevated hypothalamic set thermoregulatory threshold. So, in fact, if I say in the layman language that thermostat of the body is reset in such a way that body temperature goes up, and that may be because of various reasons, various causes, sometimes bacterial infections, sometimes viral infections, even malarial infections, or sometimes the intracranial hemorrhage or other causes. So most common cause of hyperpyrexia is brain dysfunction, like intracranial hemorrhage. And what is hyperthermia? That is the problem which we are observing nowadays because of the external environmental high temperature. It's an elevated core body temperature beyond the normal hypothalamic set thermoregulatory threshold. So it is not the thermostat in the body, in the brain, which is reset to cause high body temperature, but the usually it is secondary to exogenous stimulus like heat stroke, or secondary to adverse drug reactions like malignant neuroleptic syndrome or malignant hyperthermia, where body is not able to reduce the temperature of core temperature of the body. The thermostat does not play any role, but because of the external factors, the body temperature goes up, and that is where what we call as hyperthermia. So that is the basic difference between hyperpyrexia and hyperthermia. In hyperpyrexia, the most other causes of the fever, brain tells the body to raise its baseline temperature above normal. So that is where the hypothalamus comes into play to order the body core temperature to go up, and the body responds to the brain's message and raises its temperature to a new baseline, and that is what we call as hyperpyrexia. This reaction normally happens as a result of an infection or trauma, as I told you earlier, that there are many causes where it can cause hyperpyrexia. And in hyperthermia, it's what happens, that how does it different from hyperpyrexia? That hyperthermia is a medical term for the uncontrolled rise in the body temperature due to excess amount of body heat generated. And usually, these are the exogenous factors, not the factors which are inside the body. So that is why hypothalamus does not play any role in that. So in hyperthermia, the brain is not regulating the rise in the temperature the way it does with the other fevers. Rather, the body cannot handle the heat from the environmental causes, and so it overheats, and that is what hyperthermia is, and that is the cause of increased morbidity and mortality in summers whenever the environmental temperature goes up. And these are the cases which we are getting in the hospital, in the emergency wards nowadays. So for hyperpyrexia, CNS pyrogens, cytokines, or these type of inflammatory markers, they are responsible for the hyperpyrexia, which is seen in the neurological trauma or infections, or pontine hemorrhage or intracranial hemorrhage. Exogenous pyrogens, if we talk about, these are microbes on their toxins, like lipopolysaccharide endotoxins, which are produced by gram-negative bacteria, or enterotoxin, which is produced by Staphylococcus aureus, the gram-positive bacteria. They cause the release of pyrogens, which causes the body temperature to go up, and they belong to toll-like receptors, ligands, that is TLR ligands, where they affect the most, and thus core body temperature goes up. The pyrogenic cytokines, specific cytokines which are produced upon activation of toll-like receptors, they are like interleukin 1, interleukin 2, various interleukins, TNF, tumor necrosis factor, as well as ciliary neurotrophic factors. So these are the well-known cytokines or chemicals which are pro-inflammatory and which are once released by various organisms which invade the body of a patient. They cause the release of these factors, and then they affect in such a way that core body temperature goes up. Cytokines trigger the hypothalamus to raise the set point to febrile levels, and thus body temperature goes up. So causes of hyperpyrexia, usually instances of hyperpyrexia are associated with viral or bacterial infections. Some other causes like intracranial hemorrhage, viral and bacterial infection usually more commonly we find in our clinical practice and indoor patients. Intracranial hemorrhage, in some cases, the bleeding in the brain causes hyperpyrexia. Typically, pontine hemorrhage is known to cause hyperpyrexia more often. So the accidents or other traumas and strokes are the most likely cause of intracranial hemorrhage. The bleeding in the brain can affect an area of the brain that is particularly the hypothalamus, which is responsible for regulating the body temperature, and thus thermostat is set in such a way that core body temperature goes up. Sepsis is also a rare cause of hyperpyrexia and may result. Sepsis is potentially life-threatening response to an infection, and it stimulates the immune system, where overwhelming immune system response gets into the blood, which may cause organ damage or failure. And usually these septic conditions causing hyperpyrexia is it usually increases the morbidity and mortality in large number of patients. Even in anesthesia, people may experience, some people, hyperpyrexia due to direct side effects of general anesthesia, occurring when there is an underlying disease of the muscles. So thus, in these cases, the person's temperature rapidly goes up, and thus requires the readjustment by the anesthetist to lower the body temperature. Even in children, sometimes we get Kawasaki syndrome, or a disease which is a potential cause of hyperpyrexia, and quite well-known Kawasaki syndrome, which causes inflammation to the medium-sized arteries throughout the body. And one sign of Kawasaki disease is high fever, which can result in hyperpyrexia if left untreated. So these are some of the common causes of hyperpyrexia, which has been described in the literature. So hyperpyrexia can also be the presenting symptom of intracranial hypotension. That is very interesting to note, that it has been described in Neurocrit Care, the journal, way back in 2018, that high-grade fever with worsening intracranial hypotension that is likely secondary to hypothalamic dysfunction. And again, the thermoregulatory mechanism of the body is disturbed, where the core body temperature goes up. So spontaneous intracranial hypertension might be difficult to diagnose, yes, especially if it presented with non-classical symptoms of like fever. Thus, physicians should be aware of such situation where the hypothalamic dysfunction occurs because of the intracranial hypotension. That is very important, that clinician should always keep in mind. Well, there are a few interesting case reports of hyperpyrexia in the literature, where I would like to mention a few cases. There was a case of extreme hyperpyrexia of uncertain origin, and it has been described that 109 degree Fahrenheit is the highest human temperature which is recorded in the medical literature. So that was the extent. None of the fever-producing conditions that the patient suffered by themselves or in combination have been known to produce this rare reported degree of hyperpyrexia of 109 degree Fahrenheit, which was reported from State of Highland, New York. Well, with traumatic spinal cord injuries, sometimes from thoracic 6, the thermoregulatory mechanism can be impaired due to interruption of neural pathways, and which occurs to and from the hypothalamus, and thus the thermoregulatory mechanism is also disturbed, where core body temperature goes up, causing high body temperature or high fever. Another case report is about life-threatening Parkinsonism hyperpyrexia syndrome. And that is very important, very interesting to note. Following bilateral deep brain stimulation of subthalamic nuclei. Usually in Parkinsonism, nowadays, it is an interventional therapy of DBS, or deep brain stimulation, of the subthalamic nucleus, where the dopaminergic pathways are usually intervened with, and thus the symptoms of Parkinsonism are relieved to a great extent. And neurosurgeons, they prefer to do for the complete recovery of these patients from Parkinsonism. But sometimes what happens, that Parkinsonism hyperpyrexia syndrome is a neurophysiological reaction to acute withdrawal or decrease of central dopamine levels. What happens, that with the intervention of the dopaminergic pathways, it's a severe complication with the decrease of central dopamine levels, that is characterized by rigidity, change in conscious level, fever, hypertension, and autonomic instability that can be fatal. So sometimes this is a known complication, although very rare, but it occurs when neurosurgeons, they interfere and do deep brain stimulation in Parkinsonism patients. So Parkinsonism hyperpyrexia syndrome shares many similarities with neuroleptic malignant syndrome, which is known to cause hyperpyrexia, and successfully treated with administration of dopamine agonist, fluid replacement, and activation of deep brain stimulation can give relief from hyperpyrexia in this Parkinsonism hyperpyrexia syndrome. Another interesting case which was reported was a case of anecdotal leptospirosis, which presented with rectal bleeding and hyperpyrexia. And this case report was there in Disease and Molecular Medicine journal. Leptospirosis actually is a globally widespread zoonotic infection which can be caused by Leptospira, that is the organisms. And the main clinical symptoms are, of course, fever, which can be sometimes very high, septicemia, headache, fatigue, and myalgia. And these are very common symptoms which can occur in any of the disease processes. But then clinicians should know and identify the cause of leptospirosis also for hyperpyrexia. This report describes a case of leptospirosis following a course with hyperpyrexia for the first time in the medical literature, and which always should be kept in mind while making a differential diagnosis in a patient with hyperpyrexia. Another important condition is whenever the neurosurgeons, they do hemispherotomy and a role of unconventional therapy in the patients with the brain injuries, and there the hyperpyrexia follows. So post-neurosurgical hyperpyrexia is not uncommon, and it could be due to both infective and non-infective causes, blood transfusion, vascular injuries, even intracranial pontine hemorrhage, operative site infections or meningitis, or extensive tissue damage are common causes for new onset of post-neurosurgical fever. And again, the same mechanism of hypothalamus thermoregulation defect which occurs after hemispherotomy is the cause for hyperpyrexia after neurosurgery in these patients. So conventional antipyretics may be ineffective in controlling fever. And importantly, one should know that chlorpromazine may have contributed to reduce severity and duration of hyperpyrexia, along with other measures which can be considered early in such scenario. So the neurosurgeon should know that sometimes because of the surgical intervention, the regulatory mechanism of the body is disturbed, and in that case, it's not antipyretic, but it is chlorpromazine, which may be effective along with the other measures. Another case where hyperpyrexia in a patient with left ventricular assist device, a diagnosis beyond the obvious, that was reported in Interactive Cardiovascular and Thoracic Surgery journal. So this case also highlights a significant proportion of left ventricular assist device patients is treated with serotogenic agents, and that may predispose them to appearance of serotonin syndrome, which is a potentially life-threatening conditions. And very importantly, it is very interesting that the clinician should remember that whenever escitalopram or citalopram, along with omeprazole, which is known H2 receptor agonist, these are the combination of these two, escitalopram with omeprazole. It is attributed to this hyperpyrexia in these patients with left ventricular assist device. So that is attributed to co-administration of two commonly prescribed medications like escitalopram and omeprazole. So this should be remembered, and this combination should be avoided because it also disturbs the thermoregulatory mechanism of the body. So hyperpyrexia, again, an interesting case where antidepressants overdose may also cause the core body temperature to go up and can cause the high body temperature. This report was published from Japan, various departments, where cloamipramine, amoxapine, amitriptyline, and milnacipran. So these are known, commonly used antidepressants, which have got anticholinergic effect. So the hyperpyrexia is observed in present case may be caused by combined effects of increased heat production and interference with heat dissipation. So chlorimipramine and amitriptyline have got the potent anticholinergic properties, which again causes the disturbance in the neurogenic transmission of the production of heat as well as dissipation, and thus disturbance in these two processes can cause hyperpyrexia, and thus hyperpyrexia suppresses the cardiac performance while also increases the arrhythmias and thus increasing the morbidity and mortality in large number of patients. So one must remember that whenever we are using antidepressants like amitriptyline or amoxapine or chlorimipramine, we should be very cautious for hyperpyrexia to be noted. Well, so these were the interesting cases which I could find in the literature. Now, how to manage hyperpyrexia, that is important. The objective in treating fever are to first reduce the elevated set point of the hypothalamus and then to facilitate the heat loss. That is important. So rapid reduction in the elevated core temperature is mandatory. And then after that, we should always at the same time treat the underlying cause. So aggressive management of body temperature is commonly agreed to be essential and suggested to improve the outcome in these patients. Whether if it is because of the bacterial or viral infection, we should treat accordingly the control of the infection, as well as we should use antipyretics and cold sponging, where we should be able to dissipate the temperature, the heat from the body, and thus bring down the temperature and relief from hyperpyrexia. So management of hyperpyrexia, actually, as well as the pharmacotherapy is concerned, antipyretics, acetaminophen and paracetamol, these are the preferred drugs. Cooling blankets and cool water sponging is important. The peripheral cooling with cooling blankets can be counterproductive sometimes if we cool it very rapidly, because in the absence of antipyretics, cold receptors in the skin trigger reactive vasoconstriction and thus reduce the heat loss mechanism. So one has to balance, and balance in such a way that we should do the tepid sponging. It should not be very sponging with a very cold water. And at the same time, antipyretics should be used so that to bring down the core body temperature. The thermoregulatory effects, if we realize this pathophysiology, we are better placed to manage such type of cases. Sweating and peripheral vasodilatation are the major mechanism by which heat loss can be accelerated, and we must remember that. So that is why the sponging with very cold water should be avoided. In a warm environment, evaporation of the sweat from the skin is the most important mechanism of heat dissipation and thus bringing down the core body temperature. Heat loss from the skin by the convection and radiation is maximized by increasing skin blood flow to facilitate the sweating and thus helping in bringing down the body temperature. And actually, if you see that human body possesses two type of sweat glands. One is apocrine glands, sweat glands, and the other are eccrine sweat glands. The apocrine sweat glands are concentrated in the axilla, and they produce milky sweat rich in carbohydrate and proteins. They are adrenergically innervated and respond to emotional stress as well as to heat, and thus sympathetic overactivity causes the release of sweat from apocrine glands in the axilla. Secondly, most of the glands which produce thermal sweat are eccrine glands. These are cholinergically innervated and distributed over the entire body, but the largest number of eccrine glands are on the palms and the soles. So eccrine sweat is colorless, odorless, and it's a devoid of protein. So whenever we have to do the cold sponging with the tepid water, we should put the cloth or the sponges with water, soaked in water, that should be put either in the axilla for relieving the apocrine glands, or in the palm and soles for eccrine glands. These are the three most important part in the body which should be targeted with a tepid sponging whenever we have to do the sponging in a patient with hyperpyrexia. So that is very, very important, that anatomy we should know, and thus the tepid sponging can be more effective. So axilla, palms, and soles, these are the three areas. If we do effectively, usually it helps in bringing down the temperature without any side effects. So the thermoregulatory effectors are that cooling is best achieved by evaporation from the body surface. Sweat that drips from the skin does not cool the body, and sweat evaporated from clothing is considerably less effective. Each liter of completely evaporated sweat consumes about 580 kilocalories of the heat, so that's not very effective. It is the tepid sponging which is helpful. The vascular response to heat stress is continuous vasodilatation and compensatory vasoconstriction of splenic and renal beds. And that is how the heat is dissipated from the body. These vascular changes are under neurological control, whether adrenergic or cholinergic, and allow heat to dissipate quickly and efficiently, but they place a tremendous burden on the heart. So it should be done very meticulously and properly so that we get the maximum results of reducing the body temperature. So fast facts on hyperpyrexia. I would like to, recap whatever I have said so far, that hyperpyrexia is an emergency that needs immediate attention from the medical professions. Intracranial bleed like pontine hemorrhage or viral or bacterial or fungal infection are the common causes of hyperpyrexia. Viruses that can cause hyperpyrexia include enterovirus, or roseola or rubiola, etc. Hyperpyrexia is associated with the body temperature of more than 106 degrees Fahrenheit. Typically, treatment for hyperpyrexia focuses on antipyretic and the underlying disease process treatment, whether antibiotic we have to give or antifungal. The outlook of hyperpyrexia depends on the underlying conditions causing the state of very high fever and promptness of the disease of the treatment with the tepid sponging. Now, after that, I would like to come up 2, 3, 4 slides about hyperthermia. And again, I would like to remind that hyperthermia and hyperpyrexia are not synonymous terms. As I told you, that elevation of core body temperature above normal diurnal range due to failure of the thermoregulation causes hyperpyrexia. Hyperthermia is not synonymous, but with the more common signs of hyperpyrexia, which is induced by cytokines activation and inflammation and regulated at the level of hypothalamus or thermostat of the body. So what is hyperthermia? Hyperthermia is most commonly observed in the persons who work or exercise in hot environments and produce heat faster than the peripheral mechanism can lose it. So nowadays, as there is a high environmental temperature with the heat stroke, usually hyperthermia occurs. Hypohydration is a major cause of hyperthermia, that we should realize that it is if the patient is not properly hydrated, then the body temperature goes up. But here, the hypothalamus or the thermostat of the body has got no role to play. Hyperthermia can be rapidly fatal, and it is important to make the distinction between fever and hyperthermia, as treatment differ from that of mild to moderate fever only. Hyperthermia does not respond to typical antipyretics, since there are no pyrogenic molecules which are involved in the body mechanism to cause high fever. So that is very, very important for the clinicians to know, and that makes the difference as far as the treatment part is concerned. So causes of hyperthermia: stroke syndromes, certain metabolic diseases like hyperthyroidism, serotonin syndromes, environmental factors like heat stroke, effects of pharmacological agents that interfere with thermoregulations like atropine or the drugs which has got the cholinergic effect, the recreational drugs, ecstasy, where it causes, due to the loss in heat dissipation, causes vasoconstriction and heat production via uncoupling protein 3. Certain anesthetic drugs, a rapid uncoupling of oxidative phosphorylation, and thus can cause malignant hyperthermia. Certain neuroleptic drugs can cause the body temperature to go up, and thus there is a syndrome called neuroleptic malignant syndrome, where because of the neuroleptic drugs, the body temperature goes up. Well, the pathophysiology: the setting of thermoregulatory centers during hyperthermia remains unchanged and at normothermic levels. So hypothalamus does not play any role, while body temperature increases in uncontrolled fashion and overrides the ability to lose heat, and that is why the hypohydration or dehydration occurs. Exogenous heat exposure and endogenous heat production are two mechanisms by which hyperthermia can result, and it can cause dangerously high internal temperature with increasing morbidity and mortality in large number of patients. So the diagnosis of hyperthermia, which should be established, is with the preceding history of heat exposure. That is very, very important. Here, history becomes very important with the preceding history of heat exposure or use of certain drugs that interfere with normal thermoregulation. There is no rapid way to differentiate between elevated core temperature due to fever or from hyperthermia, but it is the history taking only that gives us the clue that the patient is having hyperthermia and not hyperpyrexia. Immediate events prior to the onset of hyperthermia usually play an important role in determining its cause. So, once hyperthermia occurs, how does it differ as far as the management is concerned from hyperpyrexia? The management of hyperthermia involves the crucial to identify and treat the underlying cause. If it is the heat stroke, we should keep the patients in a cooler environment. Rapid reduction of body temperature can be accomplished by cool or tepid, not cold bathing. That is very important. Again, I would like to emphasize, preferably using damp sponges. Cooling blankets are of potential danger because it can cause excessive vasoconstriction, where it can prevent heat loss from the skin surface. Intravenous fluid should be administered for dehydration for the patients who are having hypohydration or dehydration. So proper hydration and tepid sponging, these are the two measures which can give relief in those patients with hyperthermia, because antipyretics are of no use as far as hyperthermia is concerned, because of no pyrogens or no release of cytokines or other factors, pyrogenic factors in the body. So one must remember that paracetamol or acetaminophen has got no role, but it is the tepid sponging as well as hydration, which is very, very important. So the treatment for hyperthermia is that we should make the patient comfortable and rest. We should put the patient in the cooler environment. We should assess the volume status, orthostatic changes, blood urea nitrogen, hematocrit, which can go up with the dehydration, and even serum sodium or electrolyte imbalance. The fluid replacement is very, very essential and should be done appropriately and as soon as possible. Normal saline should be used to replete volume if the patient is orthostatic. Replace free water deficit slowly to avoid cerebral edema. And that is also very, so both ways we are in cash 2 situation. So it should be used properly and judiciously so that we can have a good effects and early recovery of these patients from high temperature. Well, this is my last slide to summarize that hyperpyrexia is usually fatal if untreated. In CNS, severe infections is detrimental, heralding poor prognosis and adding to morbidity and mortality. Even aggressive management of body temperature is commonly agreed to be essential and is suggested to improve outcome in these patients with intracranial pathologies. Treating the underlying cause and rational use of antipyretics are the cornerstone of managing hyperpyrexia. While for hyperthermia, it is the cooler environment, tepid sponging, as well as hydration, proper hydration, which is very, very essential to treat the conditions of hyperthermia. So, my dear friends, I would like to end my talk here and would like to thank all of you for your patient hearing. I think I have made a point a little clear that how can we differentiate between hyperthermia and hyperpyrexia. And the management strategies are also a little different. And if we practically follow these guidelines and identify these patients a little differently, we are able to manage these patients and we can increase the morbidity and mortality and we can cause the improvement in the health of these patients. Well, with this, I would like to stop here and would like to take any questions if there. Thank you very much.
Thank you so much, sir, for taking out your precious time and sharing your knowledge on this topic, sir. I definitely think this knowledge will definitely help all the participants who have joined this session, sir. Sir, we have received some questions from the participant. If you allow, with all your permission, shall we take these questions?
Yeah, sure.
Yes, sir. The first question I can see is from Amit Jain, and he is asking, how would you approach a case where hyperprexia is associated with a rare or emerging infectious disease? What's your point of view on that, sir?
Uh, I would also like to see the questions if I can see on the screen. Would you please repeat the question?
Yes, sir. The question is from Dr. Amit Jain. He is asking, how would you approach a case where hyperprexia is associated with a rare or emerging infectious disease?
Okay. Okay. So for identifying the infectious disease, we have to, again, the history is very, very important. Yeah. Let me make it full screen and then we'll have it. Okay. So for the history is very, very important. One, where you have to see whether the patient was exposed to any environmental high temperature environment or it was just a patient who has developed some infections, otherwise he was all right, and suddenly he developed some infections which are there to cause the high body temperature. And after that, we have to investigate properly. If we see the emerging infections, we will see the total count, the hematological values, where it will show the acute infection, and we'll identify the infections, whether it is a bacterial infections or viral infection or fungal infection. And then accordingly, we have to treat these with the various drugs to treat the bacterial infection and viral infection. At the same time, the antibiotics or antifungal are to be used with judicious use of antipyretic drugs, because this is because of the pyrogens which are liberated in the body and causes little disturbance in thermoregulation. So antibiotics or antifungal or antiviral drugs, along with proper hydration of IV fluids. These are the mechanisms, these are the three cornerstones by which we treat these infections. And of course, to identify whether it is hyperthermia or hyperpyrexia, as I told you, the history taking is very, very important to identify whether the patient had any exposure to heat environment or it is because of any infections in the body.
Thank you so much, sir, for sharing your insight on this question, sir. Moving forward, one more question from Dr. Sao, and he's asking, what are the, how do you determine the appropriate duration of follow-up for patients who have experienced hyperprexia?
Okay. For hyperpyrexia, of course, the patient's response gives us the clue. These serial investigations, whether it is markers which we see for the inflammatory markers, that these are important. For the assessment of infections, we see the total count. Again, both the extremes, whether high or whether very low, both the extremes of the TLC or total count in the blood can be an indicative of serious infections. Then severe procalcitonin levels tells us the extent or severity of the infections. Thirdly, the symptomatology, that the patient's temperature is going down or coming down to normal, hydration is proper, urine output is proper, the again the renal parameters, blood urea nitrogens, these are improving, he's passing good amount of urine, and the level of sensorium and the clinical condition of the patient tells us that how should we go ahead with the treatment. And at the same time, if it is bacterial infections and there are sorry, one important theory or approach for treating these patients with the antibiotics is that we should hit early, hit hard, that we should use the maximum dosage of good antibiotic to control the bacterial infections. And then once the improvement is there, down regulating the antibiotic regimen is also very, very important, which most of the clinicians, they fear to do because of the recurrence of the disease process. And that is why the resistance against the antibiotics is happening in the and that is becoming a very major problem as far as the treatment part is concerned. So one must remember that you should hit early, hit hard, and then gradually with the improvement of the patient, we should downregulate the antibiotics for a better outcome.
Thank you so much, sir. You have explained really well. I hope this will be helpful to the participant that Dr. Saw who have asked this question, sir. We have one feedback from Dr. Agnihotri, and she has written, Sonia Agnihotri, she has written, wonderful presentation and well explained. Thank you, sir.
Thank you. Thank you very much.
Okay, sir. And as I can see, sir, there is no more questions, sir. I hope you have done justice to this topic and you are able to clear all the doubts related to this topic, sir.
Okay.
Okay, sir. As there is no more question, with all your permission, shall we conclude this session for today?
Yeah, thank you. Thank you very much. I would also like to thank all the participants who have joined this evening for this very important subject, because most of the time we discuss about diabetes and cardiology and hypertension. So this was one topic which is very pertinent for the clinician to use in their clinical practice. And in today's scenario, it becomes all the more important for us to assess. Thank you very much once again to all of you. And thank you very much to IGCP Group for giving me this opportunity to interact with my colleagues.
Welcome, sir. And we would like to see you in future also, sir. Till then, take care of yourself, sir. Thanks for your time once again. Take care.